a hint of a potential infection, the patient gets antibiotics, even though a lot of times they don't even need it.
Right.
But yeah, and the work of Coley, obviously led to some of the newer immunotherapy
Yeah.
agents with like the one CPG.
Oh yeah.
CPG is
Yeah.
toll-like receptor
Yeah.
agonist.
Oh yeah.
That was carried on by Lloyd Old, who worked with Coley's daughter, and they discovered that I think in the 70s.
I actually quoted him in the
Uh,
timeline of immunotherapy that we recorded
yeah.
before you showed up.
Okay, yeah,
Yeah, because I was going, told you
yeah.
before, I was going through important milestones in
That's
immunotherapy, and Old is in there.
that's
Yeah.
obviously he did a lot of work and in the TLR,
Oh yeah.
particularly CPG, the innate immune response. I mean, it's the things that one thing, the immune system needs to know there's a problem. If the immune system doesn't know there's a problem, then, well, there's a real problem because
Yeah.
it doesn't know what to attack. And these, stimulators of the innate immune system, the immune system that doesn't know what it's supposed to attack, but knows there's something going on, it goes and says, okay, hey, come here and check this out. We think something's a problem. That's what the innate immune system, that's what those TLR agonists like CPG do. They come in and say, oh yeah, we should attack this or we shouldn't. And that's what we do is we like first bring in the immune cells, and then we use other drugs to say, yeah, it's correct. You're supposed to come here and attack this. And so, that's why you have to kind of do some things in a sequence where you start with a priming to hit the innate, and then you start doing like stimulation. So certain agents that will stimulate the activated T cells or other immune cells that are there, and then the checkpoint phase where the immune system's getting shut down, but then now you go heavy to try to stop that.
Yeah.
So
Yeah, there's two things I don't want to forget here. But one is precision therapy stacking. That's a phrase I like to use. And you're talking about the therapy stacking because people look at cancer and the way the mindset is with cancer, it's sequential.
Yeah.
Okay. Neoadjuvant chemo, surgery, then radiation. It's a very sequential process, as if cancer is going, oh, now the chemo's coming, I got to do that.
Right.
So it's a dynamic process. So there's that, but then it's connecting the gut to immune dysfunction.
Yeah.
Talking about the innate immunity. So I think the point you touched on there, Jason, was brilliant about it's the combining of the therapies.
Yeah.
And you've recognized that, I've recognized that, but again, we bring different experiences to that same point. But you're actually implementing that in what you're doing in more of a focal, direct approach to the tumor cells, right?
Yeah.
The cancer.
Yeah. And you look back on things. I mean, particularly, I always think about, and obviously, like when we were learning and training at the time of like HIV being bad, and sort of we went through where
that was our days.
treatment, right?
Yeah.
But at first, when we were at LSU, everybody was dying, and what they do, they would give the patient one drug, and then when that failed after about a year, it was the second drug, and when that failed after a year, it was the third drug.
Right.
Then they realized, but it was really by a mistake, I believe. What I understood was that when they were doing studies, they were supposed to give like placebos and in certain drugs, but they made a mistake, and they actually gave people all three of the drugs at once. And those were the ones that did well. And that led to the triple therapy for HIV. But yet, that seems so obvious. You would think that's obvious. Just use all the drugs. But for some reason, in oncology, they are getting better. I mean, you are starting to see now chemo plus immunotherapy. But generally, they're like, okay, let's give the patient cyclin-dependent kinase inhibitor. Okay, that failed. Okay, well, now, let's do a PARP inhibitor. Let's do that. And it's like, but not stacking all the different ones together.
Yeah.
And so it just seemed obvious, but now clearly some of these drugs do have side effects, and so you start stacking them. That is the advantage of the intratumoral approach, because
and your lower dose,
you don't have those type of issues. And and again, the other thing is, it's nice when you're attacking a tumor. We like to see what it does. Then also I look and see, what are the other tumors doing? I hit this one. Did that tumor, is it changing? Okay, yeah. And then when we start seeing, oh yeah, this thing is really going, then we're just gonna start throwing that and heating it up.
That's a beautiful transition, because one of the things I wanted to touch you on is, you're familiar with the abscopal effect.
Sure, yeah.
And this is a concept that I think was it originally born out of radiation, where you radiate a tumor and it induces a systemic effect.
Yes. Yeah.
This has been described in other arenas as well.
Yes.
So with your therapy, now we're not talking about radiation here, but this has been shown in hyperthermia, but you're talking about ablative techniques, which you could say hyperthermia is that as well, in part. Are you seeing systemic effects? You're kind of alluding to that. Are you seeing systemic effects from a direct intratumoral therapy like what you're talking about?
Definitely, definitely, and that's mainly what we're doing, because of course we're particularly doing a lot of advanced cases. So for us, it wouldn't be really helpful if we're only treating the one tumor and we get a response there, but we don't get a response anywhere else. But it's amazing. You treat those one areas and you see the response. I mean, complete responses everywhere. The other thing we're always trying to figure out is, okay, do we keep treating this one tumor where we're doing really well here, or do we split out? Do we do others? Those are all the things we're still trying to sort out. I think it's different in different cancers. A lot of times we find if we hit 2 spots, that's better, probably because we're getting, more diverse antigens.
Yeah, heterogeneity. You're really tackling that on multiple fronts.
Yeah.
It's really interesting because when you look back at the initial push in immunotherapy, they were, using inoculation, smallpox, and these kind of things. And so, in fact, I was highlighting, I think she was a Princess of Wales. She volunteered up 6 people that were in prison to get, inoculated.
Yeah.
And then they they got over the infection and they sent them out into the general public.
Yeah.
And of course there was a massive infection ongoing in the community, and none of them got sick. Right. So they said, okay, fine, you have your freedom.
Yeah.
But that shows you the power of the immune system. And so with your therapeutic approach intratumorally, with all the immunotherapeutics and all the great therapies that you're providing at one time, you're really tapping into that, not just a short term, not just a focus issue, but a widespread systemic long-term duration effect.
That's right.
But you're not creating anything new, you're just taking advantage of what's there.
Right.
The immune system. Yeah. And I think that's fascinating.
Yeah, a lot, obviously there's a lot of interest right now, like in CAR T therapy, which, looks good, but CAR T is one-dimensional. I mean, it's one antigen, and we're creating that immune response in the tumor. So we have the diversity of antigens. We have the other thing, CAR T, obviously very expensive, it's very difficult to do, and this is a much better process by essentially making that vaccine inside the body.
Yeah. So. Yeah, and again, I've said this before, best answer to cancer, don't get it.
That's true.
Nobody wants it. Bad things happen to good people all the time. But beyond that, the best answer to cancer is the immune system, because the immune system is the body's defenses against all enemies, foreign and domestic. And you're just using that.
Yeah.
It's interesting you talked about, the lower dose.
Yeah.
And, it's really interesting. I'm an advocate for lower dose chemo, metronomic chemo. 5-10%. And in fact, when you look, it's very similar to what you're describing. You're just doing it more, intratumorally, is that the lower the dose you go, the more immunomodulatory it becomes.
Yeah, that's true.
Stimulating natural killer cells, downregulating Treg cells, not wiping the innate immunity out, but actually stimulating it, which really fits exactly in what you're describing. And so you believe that the abscopal effect is real.
Oh, it's real. It's definitely real.
I do too.
I've seen it many times. Thankfully. It's it's as we say, treat locally, act globally.
Oh, I like that. So that's very good.
Yeah.
The other thing I wanted to touch on, because your history is you innovate in a lot of areas.
Yeah, that's true.
Yeah. And you mentioned this to me when we talked yesterday about you're innovating in another area. And I'd love to talk to you off script about that as well, the AI and that kind of stuff.
Sure.
But the gut.
Yeah.
Because, we know that in many ways the gut is the key to immune function. Yeah. And we know that, the bacteria, the gut microbiome actually helps to control Th1, Th2 balance, which is critical between, talk about autoimmunity and all these different things. I'd love to hear your take on, because you've already touched on it before and we've talked about it. I'd love to hear your take on the importance of the gut to what you do.
Sure.
But then where you think the importance of the gut is going to all therapies in and around immunotherapy as it relates to cancer.
Yeah. Well, one thing, of course, is that, testing of the microbiome, looking at certain bacteria. There's been several groups that have done studies looking at, and it seems like each one comes up with a different bacteria. One group says, okay, well, we looked in Bifido brevi, Bifido longum. Another group's like Akkermansia.
Yeah.
Another is fecal bacterium prosnotzi, and so another one, Clostridium butyricum. You have these different ones that they say, oh, this one seems to be the key, and then of course there's the interplay between it. I mean, some, depending on what all sort of combinations that you have. But we know that, for a lot of the immunotherapies to work, you need to have some of these bacteria present. The one thing that's been sort of classically shown is high fiber diet.
Yeah.
A diverse microbiome, the more diversity, the better the response. Interesting enough, taking general probiotics seem to be negative, seem to be hurtful because you're reducing your diversity. You're, a lot of times patients say, hey, but this has like 10 billion, it's 10 billion, but 10 billion of the same. Your microbiome is like a rainforest, and you're planting corn when you do that.
Yep.
So you want to keep that diversity, which obviously the high fiber helps. Then there are the certain key bacteria. I think Akkermansia being probably one of the top.
That's big.
Now, obviously, as we said, there is a form that you can take. Also, you can increase it. That's the other thing. It's one thing of having it, but the other thing is feeding it too, because you can have them, but you're not feeding them. If you're not feeding them appropriately, they don't do what you need them to do.
And it's interesting you mentioned the fiber and the probiotics, because was actually just getting my geek on this morning, always trying to keep up to date on the data and the research. I was reading an article. They were looking at people that took probiotics, and those that basically ate probiotics through diet, fiber.
Right.
They found that those that had the high fiber diet did better than those taking the targeted probiotics.
Yeah.
Now, they weren't looking at it necessarily to say, well, let's give these probiotics to try to augment radiation, try to augment chemo, to try to augment immunotherapy.
Right.
They were just trying to compare the two. So, I think you're probably a lot like me in this, Jason, that, definitely we can use targeted probiotics.
Sure.
And they can have their purpose. But the better answer and the connection of this to the immune system is probably diet.
Yeah. Yeah, most of the time I tell my patients, the Akkermansia, the Clostridium, take it, but only take it like 2-3 times a week. Just have it in your system, but we don't want to like overwhelm. We just want to make sure that it's kind of present, and then you sort of, nurture it with your diet. Things like camu. There's really some interesting studies going on with that. That's a fruit from the Amazon rainforest that looks kind of like a cherry. But you find it in the powder, you find it in the pills, and that functions a little bit like a fiber or like a prebiotic, a microfiber. Seems to really nourish a lot of these beneficial bacteria. There are some studies that are ongoing that look like that camu significantly boosts the response of patients on immunotherapy. So I think though, we're trying to manipulate the microbiome as an added treatment.
Yeah.
So that's where we're going. The other thing is looking at the interplay, because that's where, like with the AI stuff that we're looking at, we're looking to say, okay, if you have these genetic mutations in your tumor, your microbiome looks like this, maybe your cytokine panel looks like this, your HLA is this, all these other things, then you need this, this, and this. And we're looking for the AI to predict that and tell us the things, and so it would include okay, this person, maybe this diet's better for them, this person, these off-label drugs, that's what they need, these supplements, in this type of immunotherapy.
Precision therapy stacking.
Yeah.
I mean, but so when we're talking about nutrition, people go, there's science to support that. It's like, and not only the science to support it, but the connection between the food we put on our mouth, the impact on the gut bacteria, the metabolites, and then the systemic effects that eventually aids or is a detriment to the immune system. So you think that the gut is critical to immunotherapy that you do.
Yeah.
And I do too.
I say it's the base foundation.
Okay.
I mean, it's kind of like if you don't have that, you can't build on top of it.
Yeah, and I was actually reading another study highlighting different dietary, looking at high animal protein versus vegan versus ketogenic, etc., and how these different bacterial populations were having different effects on the immune system.
Yeah.
So where do you think we're going with the gut immune system immunotherapy cancer? Where do you think the future's holding out there for us?
Yeah, I mean, so probably, you're going to see a lot more of this fecal transplant stuff now, particularly that there's an FDA, of course, the FDA approved ones for C. diff infection.
Right, right.
But we could use it off-label, but I think you're going to find these sort of off-the-shelf versions where you say, okay, if the person takes that, that's going to really repopulate their microbiome and be helpful. And I think you're going to start seeing people all around doing that, because a lot of people, I'm sure, have poor microbiomes. But
I'd say
that's
most Western
yes,
countries
yeah.
do.
That's where, see, of course, yeah, right now with supplementation you can boost it some, but yeah, I think that's going to end up being the easier answer. I mean, for us, what we do, we say, let's check your microbiome.
Yeah.
We look for the few things that we know. There's obviously a ton of stuff we just have no idea, but look and say, okay, do you have these key bacteria or you don't? If not, can we introduce them?
Right.
Do you have something that's really bad where we can't fix this with supplementation? You're going to need a fecal transplant. And the others, there's interesting ones like pancreatic cancer.
Mm-hmm.
Pancreatic cancer was seen to be associated with certain presence of bacteria.
Yeah.
And so the question was, in a pancreatic cancer patient, are you better to wipe out their microbiome, give them oral vanc, oral neomycin, oral antibiotic to just eliminate their microbiome and start fresh and give them a new one? And that's kind of where things...
It's following the path of that thinking, that logic is kind of a bone marrow.
Right.
Replacement.
Exactly. Same type of thing. Yeah, wipe out.
Interesting.
Say this microbiome is bad, and that's where I think the newer studies were so as you and I were talking about this and alluding to it. There was this previous study where they did immunotherapy, and the patients who failed, if they did a fecal transplant from patients who were good responders, that those patients would respond. And so everybody said, okay, that's a good answer. You get your responders and you donate. Obviously, it's a little more complicated, and the FDA makes it even more complicated because they don't quite allow those type of things to take place.
Bureaucracy always complicates.
Yeah, there's but then now with the Rebiota, this is from supposedly healthy donors. I don't know how they select their people. I don't know what their consistency is. The FDA, that's one thing with fecal transplants is that they're going to want to see consistency from, if you have this Rebiota today or in a year or in 2 years, they want to see it all the same. So I guess they found a way to do that. But
so we really need to know our crap, right?
We do. You do, exactly. You do on this. So it's interesting, but the now it looks like that they're showing that type of fecal transplant from healthy donors, healthy pooled donors, may be better than even the ones that are super responders.
Wow.
And so yeah, it's saying that this person, they have cancer, and that's what they were saying. The super donors had cancer.
Right.
So their microbiome was certainly better than the non-responders, but they still had cancer.
Wow.
Whereas these people don't have cancer, at least supposedly. And so that it does kind of make a lot of sense where if you give the person a healthy microbiome, maybe that would affect a lot.
Will we ever get to the point, you think, of designer fecal transplants?
Oh, definitely. I'm sure that will be the case. I'm sure that, and again, it's going to probably come down to the AI and looking, say, this, you've got all this stuff, so you need these bacteria, you need this type of thing, and then there will be different ways they can, I'm sure, manipulate those concentrations of or different bacteria. It's clearly going to be that way.
Yeah.
I don't know how long it'll take, but yeah, it will be there.
So really, your targeting of the tumor is really transitioning to a continued targeting of the tumor that moves systemically, but now you're targeting the gut and targeting everything else that you can to stack those therapies together.
Yeah, just like trying to create the world-class athlete, giving them every advantage. It's not just the going to practice. It's doing all the other extra things that you need to do. You played football. I played football. For me, when I was kicking, football season was 365 days a year.
Oh, yeah.
I didn't take off. I kicked almost every day. Had to go to the gym, had to do stuff. I realized looking back, I didn't do enough. My father at the time told me, he said, "You think you're doing a lot, but you're not doing enough. You could do more." And he was right. But he told me, he said when you get like 40, which I passed already, unfortunately. But he said, you're going to look back and you're going to say, you know what, I could have done better. And that was true. Thankfully, though, I didn't become a professional football player, but so it's probably a good thing.
Yeah.
But yeah, you with cancer treatment, you have to do all those things to take every advantage from the supplements, diet, exercise.
Yeah.
You got to try to get the microbiome. It's not just the immunotherapy drugs. If you're only doing the immunotherapy drugs, it's like you're just going to practice. Don't ever expect to be in the Olympics or a professional athlete. So,
yeah. I mean, I can't wrap that up better than what you said there, because you just created the perfect bow to wrap this up. But let me tell you this, neither one of us played professional football.
No.
You are in your calling.
Yeah.
You're in your element, and that's why, there and back again, thank you for patient SR for reconnecting us. Took a little bit of time for me to come down here, but this is why I wanted to come and see you south of the border. First of all, because we're classmates.
Yeah.
We're going to reconnect as friends.
Yeah.
We're colleagues.
Sure.
And you're just doing some amazing, innovative work. And so what I wanted to do is come down, and obviously we have patients that come to see you, and we will definitely send more that can take advantage of that. But I think the world needs to know about the innovation that you are doing as are others. And so, man, I'm super excited to reconnect with you.
Too. Yeah.
Enjoyed meeting your wife and having dinner last night. My wife and I did. So I look forward to, maybe let's have some geek conversations, definitely.
Yeah.
Because, I approach things from a more natural, holistic, and integrative side. And you definitely are an integrative, innovative side. And I think there's a lot of, we were talking about artesunate last night.
Yeah.
Vitamin C. There's lots of ways that these things can work together in concert. Sure. Really interested in cryo, hyperthermia. Is there any benefit to this kind of push-pull? Seyfried, Dr. Thomas Seyfried talked about in a more metabolic perspective. Is there any benefit that? But just trying to expand the scope and the vision of what can be done out there, and just constantly innovated, just like you are.
Yeah.
So thank you for taking time out of your schedule, Jason.
I appreciate it, Nathan.
You are a friend. You are a colleague.
Yeah.
And I can't wait to do more work with you, man.
Yeah.
Okay.
I appreciate it. So great. So great seeing you.
And so this is Dr. Goodyear. We're going to be signing off for the Practicing with Dr. Nathan Goodyear podcast. We are down here, by the way, I didn't say this, we are in Cabo San Lucas, Mexico. Did I get that right, Andres? Did I pronounce it right? Okay, he's not going to say it because he's in the background, he's a little shot. But I encourage you to subscribe to the podcast, share it with everybody that you think would benefit from the innovative work that Dr. Jason Williams and we are at Brio doing. And the name of your clinic is Williams
Cancer Institute. Yes.
Yeah. And two, check out this book. I'm sure you can find it online wherever you buy your books. I'm sure Amazon, etc. I'm not going to lie, I have not read it, but I am going to. It looks like an easy read here. Yes, without my glasses, but it looks like an easy read. Subscribe, share this with family members, everyone you think can benefit from this amazing, innovative knowledge that Dr. Jason Williams was talking about and we discussed. So look forward to bringing more podcasts to you in the future. This is Dr. Goodyear signing off with Jason Williams in Cabo San Lucas.